My name is Dr. Elizabeth Gosden, and I'm an assistant attending orthopedic surgeon at the Hospital for Special Surgery on the hip and knee service. So I see patients that come in with hip or knee pain, or patients that have hip or knee replacements and that have problems or pain or instability around those replacements. So a periprosthetic fracture is a fracture that occurs around a hip or a knee replacement. And since I did training both in orthopedic trauma as well as hip and knee replacement, I have a special interest in treating patients with these fractures. I think the dual training has given me ability to either fix these fractures with plates and screws or other implants that we can use to get those fractures to heal, or in some cases it may make more sense to revise the hip or knee replacement, which I'm trained to do as well. So I think each patient is an individual and needs to be treated in a unique way. I like to say I don't treat the x-ray, I treat the patient. And ultimately you can have a patient that's got a very severe x-ray, but they're still very functional and they've been told they need a knee replacement, but they're not having problems. And I absolutely would advise that that patient not go through surgery, and I'll continue to follow them to maybe prolong any life they have out of that knee. But I think the decision to ultimately go through with the surgery is really a patient decision, and I think of my job as one to inform that decision as best as possible. I use computer navigation as well as robotic surgery, and I tend to tailor the choice to each individual patient and what works for them. I think both are very helpful tools for the right patient and the right problem. Basically, these tools help us make our cuts in surgery and our placement of the implants just a little more precise. A lot of patients come to me because of my trauma background with deformities after a fracture or another injury where their anatomy is not normal. And typically in conventional hip and knee replacements, we use anatomic landmarks to place our implants. In such patients that don't have normal anatomy to begin with, computer navigation or robotic surgery can be very helpful to position our implants exactly where we want to position them. The most amazing thing for me is when a patient walks back into the office and says, "I'm so much better than I was the day I walked in." And that's so rewarding.